The anterior choroidal artery is a thin artery within the brain that exits an anterior portion of the circle of Willis and is a distal segment of the posterior wall of the internal carotid artery. The artery feeds deep into the brain and is responsible for supplying several anatomical structures within. Such structures include the cerebral peduncle, medial temporal lobe, posterior and medial part of the lentiform nucleus, lateral thalamus, lateral geniculate body, optic radiation, medial area of the pallidum, posterior limb of the internal capsule, posterior part of the putamen, choroidal plexus, and the paraventricular tail of the caudate nucleus. However, there is a large variation between individuals in regards to where the anterior choroidal artery supplies due to anatomical differences from person to person. Due to the anterior choroidal artery's smaller diameter, it is extremely vulnerable to infarcts, which can be caused by ruptures, vasoconstriction, mechanical compression, or blockages. Such events can have devastating results for those affected. Due to the areas that it supplies, these types of infarcts have a high progression rate and often poor functional prognosis. Strokes involving the anterior choroidal artery account for 8.3 to 11% of patients who experience acute ischemic strokes. The most at risk are those who are hypertensive or suffer from hyperlipidemia, diabetes, hyperhomocystinemia, peripheral arterial disease, previous strokes, as well as those with atrial fibrillation and coronary heart disease. Individuals that smoke or use antihypertensive and antithrombotic medication were also shown to have increased risk. Acceleration, deceleration, and high velocity impact traumas like car accidents that can cause shearing stress have also been known to cause anterior choroidal artery infarcts. Within the individuals affected, 40 to 60% of them reported neurological deficits, and up to 90% of them experienced motor deficits. The most common presentations are hemiparesis or hemiplegia, hemianesthesia, and hemianopia. However, all presenting simultaneously is rare. Hemiparesis is the most common manifestation, followed by dyslexia, hemianesthesia, dizziness and nausea, disturbances in consciousness, then hemianopia, as well as visual field deficits. Lacuna syndromes, as well as aphasia and neglect, have also been reported in anterior choroidal artery infarct patients. However, the manifestations often differ depending on the hemisphere that is affected. The precise extent of the infarct and the area that is affected does require imaging in all possible views and sequences, as the territory cannot be isolated due to the multidimensional aspects the artery supplies. However, there are tests that can be taken that can help a practitioner narrow down the possible pathologies and help better understand what further assessment and treatment the individual requires. Firstly, the patient will be asked to do a gait assessment to see if there are any abnormalities in how they walk or move their body. General observations will then be made to assess for any changes in things such as facial tone and expression. To test for hemiparesis and hemianesthesia, each dermatome will be assessed for loss of sensation through soft, sharp, and cold touch. For the motor component of hemiparesis, each myotome will be assessed through muscle testing. This will be done on the upper and lower body in combination with reflex assessment. To test for the presence of hemianopia, which results in the loss of half of their visual fields, the 4 visual fields will be tested using a red and white marker. Finally, the patient will be asked to read a passage of text. This will assess for the presence of aphasia and dyslexia. Alrighty, so now I'm just going to do a gait assessment on the patient, just seeing how they walk, see if they're dragging their feet, how they move their arms and interact with their surroundings. So if I could just get you to walk just over there for me, and then turn around and come back. And then I'll check it in both planes. So if you do that again for me, just seeing how the arms move and how it contacts the ground. And one more time. I'll now be testing the patient's dermatomes of the upper limb, testing C5, C6, C7, C8 and T1 on both the right and left arm, alternating between sharp, soft and cold. So this will just be sharp, this will be cold, this will be soft. Do you feel the difference between those? Yep. You just need to tell me when you're feeling each one, alright? Alrighty.
Sharp. Soft. Cold. Sharp. Soft. Cold. Sharp. Cold. Soft. Sharp. Cold. Soft. Soft. Sharp. Cold. Soft. Sharp. Cold. Sharp. soft, cold, sharp, soft, cold, cold, soft, sharp, sharp, soft, cold.
I'll now be testing the dermatomes of the lower limb, alternating between sharp, soft, and cold, and see if you can tell the difference between each, alright? So that'll be sharp, that'll be cold, and that'll be soft. Can you tell the difference between those? Alright, you keep your eyes closed and just tell me which one you feel.
Sharp, soft, cold, soft, cold, sharp, soft, sharp, cold, cold, soft, sharp, soft, cold, sharp, soft, cold, cold, sharp, soft.
Now move on to the lower leg.
Sharp, soft, cold, sharp, cold, sharp, soft, cold, soft, sharp, cold, soft, sharp, soft, cold, sharp, cold, sharp, soft, cold, soft, sharp, cold, soft.
Alright, I'm now just testing the myotomes of the upper body, assessing for any weakness. So I just need you to resist against my force, alright? C1, 2, C2, C3, C3, shoulder elevation, assess against my force, C4, arms are like this, C5, elbows in like this, C6, push against my force, the other way, sorry, C7, wrist out like this, that, with this, C6, wrist this way, resist against my force, C7, have your fingers like this, C8, fingers out wide, finger abduction, T1, this against force. I'll now be testing the myotomes of the lower body, also assessing for weakness. Alrighty, so I just want to give you a resist against my force. L1, 2, L1, 2, keep your leg up, L3, resist, extension, resist. Now I want you to resist against my hand, plantar flexion, S1, plantar flexion, S1, dorsiflexion, L4, dorsiflexion, L4, great toe extension, L5, L5. Now I want you to flip onto your stomach for me. Assessing S2, weakness here, relax. Relax, now I just want you to lift your hip up, testing S2, down. I will now be testing the reflexes of the upper limb. I'll just be starting with the triceps reflex. Comparing left to right. Biceps reflex. Brachioradialis reflex. I'll now be testing the reflexes of the lower limb, starting with the knee. Lie down your stomach for me. Now doing the ankle and hamstring reflexes.
Chop it down a little bit. Relax your leg.
Now assessing the patient's 4 visual fields, alternating between covering his left and right eye and asking if he can see the red or white marker. Alright, so just want to cover your eye just on the same as me. Alright, tell me when you can see my hand.
Yeah.
What colour am I holding up?
Black.
What colour am I holding up?
Red.
Alright, tell me when you can see my hand.
Yeah.
What colour am I holding up?
Red.
What colour am I holding up?
Black.
Alright, tell me when you can see my hand.
Yep.
What colour am I holding up?
Black.
What colour am I holding up?
Red.
Alright, tell me when you can see my hand.
Yep.
What colour am I holding up?
Red.
What colour am I holding up?
Black.
Alright, now just cover your other eye. Go through the same steps. Tell me when you can see my hand.
Yep.
What colour am I holding up?
Red.
What colour am I holding up?
Black.
Alrighty. Tell me when you can see my hand.
Yep.
What colour am I holding up?
Black.
What colour am I holding up?
Red.
Alright, tell me when you can see my hand.
Yep.
What colour am I holding up?
Black.
What colour am I holding up?
Red.
Tell me when you can see my hand.
Yeah.
What colour am I holding up?
Red.
What colour am I holding up?
Black.
Now I'm just going to get the patient to read a passage of text, just see if there's any presence of dyslexia and aphasia, see how they read the words and pronounce them. So if I can just get you to read that out for me.
We live in a fabulous area with a wonderful community, and I'm honoured to represent you as your local state member for Maroochydore. I have a passion and track record for standing up for the community as we work together to keep people safe, rebuild the Sunshine Coast economy, invest in essential infrastructure, and grow local jobs.
Thank you. The large variation in where the artery supplies caused by the anatomical differences from person to person, combined with the degree of blood supply overlap from different arteries, means that infarcts from the other vessels, such as the middle and posterior cerebral arteries, can often be mistaken for anterior choroidal artery infarcts. Although, while many of the signs and symptoms will present very similarly, there will be variations in what the patient presents with if a stroke does happen in one of these adjacent arteries. In particular, if an infarct occurs in the posterior cerebral artery, they may present with diplopia, which would be identified in the visual field testing. They may also have difficulties perceiving colours or recognizing faces. For individuals with middle cerebral artery infarcts, while they may also present with hemiparesis and hemianopia, visuospatial neglect may also be present, which would be a notice when they are interacting with their surroundings or undergoing their gait assessment. Other pathologies like space-occupying lesions such as malignancies and abscesses, as well as hematomas caused by trauma, may also present similarly, as they may compress tissue or disrupt blood flow within a similar area. Ultimately, without imaging such as CT, MRI, or CTA, it is hard to precisely identify which branch is affected, or what may be exactly causing what the patient is presenting with. But the previous test will help practitioners decide what further testing is required.